Okay, welcome everyone. This is the Aesthetic Society Roundtable, and I've got some great friends of mine, plastic surgeons from around the country. Two here from Dallas, Texas here, Louis Strock and Jeffrey Kinkle, and of course Pat McGuire, who most of you know. All sort of leaders in the thinking about breast implants and all the iterations. I really like this session and I hope you'll enjoy it, because this is really talking about something that most of us as plastic surgeons see every day, and it's the issues as it relates to textured implants in patients who are basically not having any problems, and how we speak to them and what we do for those patients. And there's just a host of different opinions as it relates to that. And so I think we want to do a deep dive into that and understand it a little better. So maybe we'll start with you, Pat. So when you see a patient who you're just following up with a textured device and they come in to see you just routinely, do you do anything different or say anything different than you would with your patients that have smooth devices?
Yeah, I did a lot of textured implants. I liked them. I like the position stability. I like shaped implants. So I used a lot of textured implants. So I have a lot of patients coming in, and I see my patients every year. So I see a lot of patients coming in with textured implants. Now, we proactively, before like the Allergan recall last summer, had sent letters out to all of our patients with implants, not just textured implants, but we wanted to remind them that implants weren't lifetime devices. And then we told them about the potential risk of developing breast implant-associated ALCL. So we got a lot of hysterical patients come in, patients with significant concerns or patients who saw something on the news and wanted to know. So we schedule extra time for those patients. And what I talk to them about is, what is the risk? Now, if you talk about, well, it's 1 in 30,000 or that number doesn't make sense to a lot of patients. And the worst case scenario, and I published a paper in January 2017 with the CARE study 410, and at the time, there were 4 patients of 17,000 that had developed breast implant-associated ALCL. That's now up to 8. So the risk is, I tell my patients, the risk could be as high as 1 in 2,000. And even if you believe the Peter Cordero's numbers, 1 in 443, and it is a scary number. But to put it into perspective for the patients, I tell them it's a 99% chance or 99.9% chance that you will never develop this lymphoma. That if you do develop it, that it's usually obvious, 80% of the time presents with swelling of one or both breasts. But if anything changes, we should see them sooner than later. And we give them the option. We say, well, there's no guarantee, even if you do have your implants removed, that you will not develop ALCL, and they need to decide the risk-benefit to doing that. We have high-resolution ultrasound, so I ultrasound those patients. That's very reassuring to them that there's no fluid around their implant, everything looks normal. But it's a conversation I think you have to have with these patients. But I think you also don't want to fearmonger and scare patients into thinking they need to have an operation. They need to understand, so long as they're willing, the FDA is not recommending anyone have their implants removed. Their regular follow-up, see us sooner or later if they have any changes is the recommendation.
Yeah, so that's what you do. So Lou, anything different from what Pat said?
Yeah, what I would add to that is I had a large experience using microtextured shape gel. So with those patients, the data is a little different based on the material, but it's still an issue, and it's a discussion that we have with all patients about potential risk, probably about 1 in 86,000 based on Australian data for the Siltex type material. But we have a conversation about it, really emphasize the importance for annual follow-up and immediate notification if there's any change in the situation. Also explain that really the FDA does not recommend these implants just be removed just because they're there. But we have a conversation about that. I've had one patient who really had a good aesthetic result due to a family history of lymphoma, who worked at our surgery center that wanted to change the devices out to smooth, which I did, but otherwise I don't really encourage that at all. And but the key is routine annual follow-up.
Right. Jeff, anything different?
Yeah, I think just depending on the media coverage, which hasn't been that great over the last several months. I mean, I think we see episodic waves of these patients coming in. Like Pat, we sent out a note to all of our implant patients, and that generated a bunch of inquiries. We did have to educate our nursing staff just so they can answer some questions. But I think there was a lot of fear out there. But I think fortunately we can educate them on the information we know. And the vast majority are comfortable keeping their implants, at least that's been our experience. And then certainly those that aren't certainly have the option to have them removed.
So what do you think the negative part of just going ahead and changing their implants or doing a capsulectomy? Because we we really don't want to do a capsulectomy. I understand it's unnecessary surgery, but what are the other negative consequences of doing a surgery on somebody who otherwise is doing fine?
Yeah, I mean, I think there's always risk involved with any operation, whether for a cap con or any of the other things that can happen with implant-based surgery. I do think capsulectomies, particularly in the submuscular, an implant in a submuscular position, carries with it the morbidity. Just the pain alone of trying to get a normal capsule off the periosteum of the ribs generates a fair amount of discomfort for the patient. So I think they need to understand that. But if I put as a male, it's hard to put myself in their shoes, but I think if I was fearful or had anxiety, and that's what I tell them on a daily basis, then I think this is clearly an option that they should consider.
We used textured implants for a reason. We use shaped implants for a reason. I think the patients need to understand those trade-offs. And I've had a couple of patients that were just so fearful, especially some of my cancer reconstruction patients. I've had cancer once, I don't want to get it again, I want to get these implants out, get the capsule out, get a smooth implant. Well, we use shaped implants on those patients for a reason, and you have a more mobile implant, which is good in some ways, but the shape isn't good. Now we have fat grafting and all that we didn't have, but a lot of the patients, I've had 2 patients say, boy, I wish I could have my textured shaped implant back. So you have to make sure the patients understand that there's a trade-off in doing it.
I think it's very important to also emphasize in these conversations that everything we do is an evolution of knowledge. And so we picked a device when we did based on the toolbox that was available at that time. And while I still like textured implants, I've stopped using them for a variety of reasons. But I still think it's a good tool. It's a tool I miss sometimes. And I also explained to some of these patients in follow-up some of the advantages that I think many of them have gained by using the device we used over some potential issues with the newer ones we're using that we know the weaknesses of them. So, and certainly let us know if even after this conversation, if sometime later you're just really upset about this or there's some issue where it's back on your radar, let us know. We'll talk more.
The other thing that I'll just add is that, we're the ultimate patient advocates, and I think our patients trust us. There's a lot of good information on the internet, and there's a lot of bad information, and I think they're confused. So having them come in and sitting down and spending the time with them to make sure they're properly informed so they can make the best decision for them is just really important. And I think that's what our job is as their doctor.
Go ahead, Liz.
And the conversations between patients that have breast implants, whether it's on social media or in person, I've found have fed patients reaching back out to me, patients I know personally, just kind of shoot me a text, hey, can we talk? Because there's been a lot of chatter behind the scenes about related issues. So the key is just make sure that they understand the communication lines are open always.
Right. So let me make it a little more complicated. So now you have a patient who comes in because she needs to have surgery, because she maybe has a ruptured textured implant, and now you're going to already be going ahead and doing surgery. So as you've mentioned, Dr. Kinkle, that you don't want to have the risks of surgery, but now you're already going in and doing surgery. So let's make it more complicated. And it's a BioCell textured implant, and the capsule's a little bit thickened, but maybe not bad, kind of maybe a grade 2 capsular contracture. Now you're going to see that patient. Does it change your decision on whether to take the capsule out or not when you're doing that surgery? And how would you counsel your patient about that?
In that circumstance, most of the time I am taking the capsule out. I do let them know that there is some risk involved, and if we can get the capsule off very easily, there's really no reason to not do it. I think the challenge is if you have that capsule on the ribs, are you going to do that extra step to get it all off? And I think for the most part, I do, because I think we are in surgery, so why not just kind of take care of that, even though the risk is going to be very low. It's just one less thing I think that the patient potentially needs to worry about.
So Lou, would you feel differently because you use Siltex implants when you use texture, and so now you get a risk that's way less than the BioCell for the patient, and the capsule's supportive to the pocket in a way. How do you counsel your patients about whether to take the capsule out at this point or not?
Our conversation is about the data as it currently exists, from the context of it may change. So we're weighing the information we have versus our observations in the OR and what we're going to do. And I just want to make sure that the patient and I have a clear understanding about how we'll manage it. If it's abnormal at all, it's coming out regardless of whatever else we have to do on the case. So that's straightforward. If it's totally normal, And I explained that, hey, we really often view this or need it as a building material, so I have to weigh what is in the patient's best interest in terms of that decision. And we have a conversation, usually 2 conversations before we have surgery, to make sure that they're comfortable with that. If I leave a capsule in, particularly with BioCell, I take a video of it to show what we did, or if we left some things in. But I've got a quicker draw to remove BioCell capsules just by the data.
Yeah, I think that's the point, is it doesn't matter which texture you're talking about and what you see physically on the patient. So I think we all agree that in general, even with any textured implant, observation is very appropriate for most of those patients with good yearly follow-up or every other year follow-up. So you do that and the patient still wants to have a capsulectomy and implant. You just can't get past the fear. How would you manage that patient, and what would you tell them about your surgery and what will it do to minimize their risk of future disease?
Yeah, we saw a lot of that. Kind of the first wave after the Allergan implant recall, we got the people who were really worried. And those are people who just insisted they had to have surgery. We kind of made them cool off a little bit. We didn't operate on them the next week. We sat down and talked to them, the risks, the benefits. And a lot of them just said, I am just worried about this. And some of them elect to remove their implants. And I follow my patients for a long time. So a lot of these women now are 10 years older or 15 years older, and their breasts have changed. They may have had kids, gained weight. So there's someone will say, well, I just want my implants removed in a mastopexy. If I do that, I definitely try and get the entire capsule out, because I think it's easier to manipulate the tissues into a good shape. And the thicker capsules, the one good thing about the BioCell capsules, they're fairly thick compared to like a smooth saline implant. So they're not usually too difficult to get out. But you also have to realize you're expanding that pocket when you take it out. And I had one patient get a lateral malposition afterwards. So I've changed my surgical technique in that I really try and control the pocket much better. I will suture the lateral close. I'll keep them in a bra for a few months afterwards. But then the patient has to understand there's risk to a capsulectomy. Number one, hematoma, a little bit higher risk of a capsulectomy than not. And if they have a submuscular implant, there's a risk of getting a pneumothorax, which is not a minor complication. The MD Anderson data for their ALCL patients showed 4% pneumothorax rate. So not an insignificant risk with it as well. And then they have to decide, do they want an implant replaced or not? We replace with smooth. Implants are different than what they had before, so they have to be mentally prepared for that. And also, even if we remove the implant in the capsule, we have no idea if that eliminates their risk of developing or reduces their risk of developing ALCL. Now, in my mind, if I can remove the implant and capsule together, that's kind of the same operation you do to cure ALCL. It seems to me it would lower the risk, but we can't tell the patient that for sure. Either way. So either way, we have to still follow them. They have to stay educated and go into it with their eyes open.
Yeah. Lou, same or a little different?
Pretty similar to that. I think the other discussion that has to occur in the context sometimes of a lot of concern about textured implants is we have reasons we've used them.
Right.
And so we then are going to go to a smooth device, and I'm a big fan of them, but we all know, at least I certainly deal with unwanted movement as a problem late, medium to late term. You can make the pocket fit the implant, but there's a discussion with the patient that I think has to occur about that. So we know the weaknesses of all the devices we use, and I think we have to have a conversation about that just so they understand, hey, here's the newer technology, here are the advantages of it and the strengths of it, here are the weaknesses of it, so they understand, because patients do get frustrated with ongoing maintenance, of course, and we're trying to do everything we can to minimize that.
Jeff, do you do anything different now? So if you use, the texture was in there for a reason, maybe it's a chest wall that's difficult or something else, and now you're using a smooth device, or is there anything adjunctively you're doing with that patient in the surgery, like a mesh or ADMs more likely, anything to control the position of the implant?
Yeah, I think as Lewis has taught us, I mean, I think you do have to, if you're going to switch to a round implant, particularly in a submuscular position, and then you do a capsulectomy, you are going to have to control that pocket. So I think there are internal support mechanisms that we can use to help aid that. Haven't perfected that by any means at all. I think it's still somewhat challenging to control both the implant as well as the overlying skin and breast tissue. So I think I think it does present some unique challenges that you're going to have to educate your patient on. You know, I think we do use fat a little bit more, particularly in some of the more difficult types of deficiencies that we have on the lower pole. So I think that's been something that I know I've been able to bring into my practice and use a bit more.
Yeah, I found that, especially in those cases where I wanted to use a shaped device, or I would have used a shaped device, the addition of a smooth implant plus fat grafting often can help me create something more of a shaped example. Do you think about the advances in implant design? Has that helped us? What do you think, Lou? Like in just that the implant's more cohesive, optimally filled. Do you think the smooth implants of today perform differently and or better for patients compared to the past, and maybe has helped to eliminate some of the need for textured in some cases?
Here's what I would say, Brad. I think to me, the newer smooth implants, by the fact they're either more highly filled or give us a choice of the gel, or both, to me are better than all the old, more underfilled or less fully filled, whatever you want to say, the older smooth implants. So I don't use the older smooth implants anymore, and I think these are better. Now, they all have strengths and weaknesses. Ultimately, I end up using support bioabsorbable mesh such as P4HB materials frequently in my practice, particularly in revisions, to try to get some lateral and inferior stability longer term of the implant pocket. I'm 3 years into that journey, so I don't really have long-term data on this yet. I like it. It makes me more comfortable with what I'm doing, but I have to see long-term outcomes. So I think the discussion's changed a little bit. I think the implants are better. I don't think they're perfect. And but I have patients very involved in the implant selection with guidance, selection to see if they like a more cohesive gel and a little more firm feel, particularly if they're thin tissue patients where their breast augmented is going to feel much more like the implant than a patient with a lot of tissue. Those sorts of things that we run through.
Yeah. I think maybe the last thing, I'm going to ask about the advantages of what texture, why we use texture, and do you miss it still? Now that we're using smooth and you become more comfortable with smooth, there was a reason you used texture. Do you miss texture now? And if so, what kind of cases, Pat? Do you miss it?
Yeah, when I've seen, and we sent a letter out to our patients, we've seen patients from 15 years ago, and when we were using Style 410 implants, which was a biocell textured shape device, and for constricted breast, for some of my transgender patients, which now actually I do subfascial rather than submuscular, because I think you need the texture to avoid inferior and lateral malpositions on those patients. I do miss the textured implants. And you see these patients, if you got a good result with those implants, they were the best results you had, and they looked good long term. Now, we do have better implants now. Some of the more highly filled implants, I don't necessarily like always the highest cohesiveness, flipping and moving with those implants a little bit more. But some of the in between, like the soft touch is a nice implant for my transgender patients. I think for the constricted breast patients now, it's a combination of like a soft touch implant with fat. And you can get a lot of the same results. Maybe not quite as predictably off the bat. When you had an implant, you knew is the fat going to take or not take. But I do miss textured implants. And for cancer reconstructions, I think they were also very useful. And I'll see patients now for revision for malposition that, boy, I'd really like to use a textured implant on that patient. And I stopped using them in 2016.
Yeah, I would agree with that. I think it's just necessary. We each have to make our own decision about this. But to me, yes, I miss microtextured shape gel in certain situations. However, I've had to adapt my thinking, and so I'm fine with that because I do not want to make patients nervous. With our implant choice, if we're putting this device in their body, and if there are safety questions or concerns, I just think we always have to update what we're doing, and so I'm okay moving on.
Yeah, exactly. Jeff, do you feel differently about that?
Yeah, I never used a lot of textured surface implants. I agree. When I was doing more breast reconstruction, I did use a fair amount there, and then just the select congenital cases, constricted lower pole, I would certainly consider that. So I wouldn't say I miss them.
Yeah.
Because I just don't have a large patient population that I would use them in. But I still think that they probably are the best solution for some of those.
Yeah, this session is about textured people not having problems, but I do think that one of the challenges with using texture, and especially moving forward, because we still have them available in certain textures, is that when somebody gets a seroma or a late seroma, the conversation is much tougher. And the decision making is much tougher at that point in time as it relates to that. So I know that moving forward, the idea when I have a smooth implant, my decision tree becomes much simpler. Anybody feel any different about that? I think that's what I think is that just moving forward for patients that even are having problems or not having problems, it's just simpler when we use smooth implants now. And I was a big texture user.
One thing I would add to that is that my enthusiasm for microtextured shaped gel implants was in the absence of intermediate gel thicknesses otherwise.
Yeah.
And so when I say I've been an enthusiast for it, I think a whole lot of that was maybe a gel that's intermediately thick, like you were saying, Pat. So I found myself very much gravitating in that direction with smooth implants or more filled ones for those reasons, because I'm trying to get maybe what I thought I liked is actually the gel more than the texture.
Yeah, long-term results seem to maybe be the stability of the gel within the shell more than maybe necessarily the texture itself on the device. We're gonna wrap this up. I'm gonna just give each one of you just a chance to say, as it relates to textured implants, your final thing is, as it relates to textured implants, for the just general patients you're following up that you're seeing, they're either other people's surgeons, surgeons have been theirs, or your own patients, what you mostly do in them is what, Pat?
See them every year. We do an ultrasound on every one of their visits. If they don't come in for their visit, we find them and make sure they're coming in for it. I stopped using textured implants. I don't think elective cosmetic surgery or elective surgery in general and lymphoma, no matter how remote the risk, are two things that go together. So I've stopped using them. I follow my patients very carefully, and I think we owe our patients to make sure they're educated and they have the option. I think they have every right to have their implant exchanged to a smooth if they want to, but they need to go in understanding the risk and benefit.
Lou?
What I would add to that, I just trying to emphasize that we're learning more about this all the time. There's an evolution of knowledge. In about 2016, 17, when I was really thinking about really changing what I was doing and just getting away from texture totally, I went through a period where I would talk with patients. Now, if you're a worrier, and I would say something like that, everyone's a worrier. We say, okay, I get it. I think I need to change. So I would have no argument with colleagues who still think texture is important in their practice. It's just a decision each of us has to make. And in terms of my own patients, I really just strongly encourage them to come see us at least annually.
Yes.
To keep in touch, that's what keeps this safe.
And I think for our practice, misinformation drives anxiety. So the vast majority of patients that we've seen over the last several years are comfortable just seeing us on a yearly basis once they've been properly educated.
Yeah, I think they do listen to us, and I think the only thing I would add to it is just the reminder to the plastic surgeons that what we do at surgery isn't benign always, and there's a mortality. I think it's been published, the mortality from an aesthetic breast surgery is about 1 in 72,000. So when you start thinking about risks of ALCL with microtexture of 1 in 86,000 or whatever, you start to balance that what we do can have grave consequences in the occasional patient. And there was a mortality recently in California from doing an en bloc sort of BII patient. So I do think that we take that seriously. And I, like all of you, believe that we should counsel them, follow them closely, and when it comes to texture devices, support them in their decision to keep their implants, especially if they're doing really, really well. So I think that we're going to wrap it up for this session of the Aesthetic Society's Roundtables. It's been fun, and always I love it when we all agree for the most part on all of this. And for all of us here at the Plastic Surgery Channel and with the Aesthetic Society, we're really happy to have you here.